Hello everybody, welcome back. Today's topic is role of nutrition in preterm infants and neurodevelopment of preterm infants. Myself Dr. Tanuja Kabir. Today's discussions mainly over the three topics. First, immature neurodevelopment of preterm infants. Second, neurological benefits of docosahexaenoic acid and arachidonic acid supplementation of preterm infants. And third, recommendation of DHA and ARA supplementation in preterm infants. Now, who are preterm? The World Health Organization defines preterm birth as any birth before 37 completed weeks of gestation or fewer than 259 days since the first day of the woman's last menstrual period is called preterm birth. And of the estimated 130 million babies born each year globally, among them approximately 15 million are born preterm. Prematurity is an important public health priority. The global incidence of premature births are 10.6%, whereas in India premature birth rate is 13.6% and neonatal deaths associated with prematurity is 3% and rate of low birth weight baby in India is 28%. Preterm births account for global burden of disease. The burden of preterm birth is highest in low income countries, particularly those in South Asia. Prematurity is now the second leading cause of death in children under 5 years and the single most important cause of death in the critical first month of life. Infant born prematurely, especially with low birth weight, are predisposed to inferior outcomes because of inadequate feeding skill and therefore they are at risk for infection, sepsis and death. Among those who survive may experience extrauterine growth restriction or postnatal growth failure, especially if their nutritional intake is low and have impaired cognitive development and compromised learning, vision and hearing. Extrauterine growth restriction is common among preterm infants, occurring is more than 50% of very low birth weight babies. Inadequate postnatal nutrition is an important factor contributing to growth failure. Approximately 7% of infants born prematurely worldwide are estimated to have some degree of neurodevelopmental impairment, which represent a large social and economic burden. All nutrients support brain development, but certain micro and macronutrients are particularly important in preterm infants. Those are protein, glucose, polyunsaturated fatty acids, iron, zinc, iodine and folate. Evidence shows that nutrient insufficiency in preterm infants positively affects development of sensory, visual and auditory functions. Preterm infants are physiologically immature and have limited compensatory responses to the extrauterine environment as compared with term infants. Preterm infants are high risk for respiratory morbidity and may be need for ventilation. Preterm babies are more susceptible for development of jaundice, hypoglycemia and sepsis. Now, achieving of appropriate growth and development is often difficult in preterm neonates because of special needs of the preterm infant. Preterm infant have reduced innate immunity and adaptive immunity. They have low stores of liver glycogen and reduced glycogenic activity and low nutrient stores or reserve. For these above reasons, the preterm population present a high risk of postnatal malnutrition, thus the higher need for nutritional requirements. So that appropriate nutritional care of preterm infants can support early growth and development, reducing risks of growth failure. Now, the next topic is immature neurodevelopment of preterm infants. The third trimester of gestation is a critical period for prolific brain development. because in this time maximum brain development happens. The brain size increases 4 times. In the third trimester, multiple biological processes are actively taking place, including the beginning of myelination, neuronal organization, spinogenesis, and synaptogenesis. It is well established that there is a fourfold increase in brain size during the third trimester of gestation, accompanied by a dramatic increase in brain surface area with the formation of tertiary sulci and gyri. And in this third trimester is the time of maximum transfer of placental transfer of important fatty acids. Now, a specific gradient of low chain polyunsaturated fatty acid is created between the mother and the fetus. That is a result of increased the placental transport activity. The process is reflected in the difference in docosahexaenoic acid and arachidonic acid concentration in the blood of the mother versus the fetus. During the final weeks of the pregnancy, the docosahexaenoic acid and arachidonic acid content in fetal plasma is almost twice as high as in the mother's blood. The fatty acids are absorbed from fetal circulation and stored in the fetal adipose tissue. As a result, towards the end of the pregnancy, their level are several times higher in fetal adipose tissue than in the maternal adipose tissue. That is 16 times higher in the case of docosahexaenoic acid and over 90 times higher in case of arachidonic acid. During the third trimester, there is selective placental transfer of these low chain unsaturated fatty acids, which substantially increases the level of this fatty acid in the fetal circulation to meet the demands of the rapidly developing brain and retina. Preterm infants have deficit docosahexaenoic acid stores due to early cessation of gestational period. Docosahexaenoic acid status is very low. Birth weight infants remain low due to inadequate of fat stores, ineffective conversion from precursor fatty acid and a limited nutritional supply. Because of docosahexaenoic acid cannot be synthesized de novo, the developing fetus is dependent on maternal source. Most docosahexaenoic acid accumulation occurs during the third trimester of pregnancy, when growth and brain development are rapid. Infants born before this process is complete have interruption in normal low chain polyunsaturated fatty acid accretion. Indeed, preterm infants have lower docosahexaenoic acid levels than their term peers. Furthermore, in very preterm infants, this deficit persists or worsens due to decreased adipose stores, a limited ability to convert precursor arachidonic acid to docosahexaenoic acid, and poor nutritional provision of performed low chain polyunsaturated fatty acids. Now, last topic is recommendation of docosahexaenoic acids and arachidonic acid supplementation in preterm infants. Optimizing preterm nutrition is a promising avenue to mitigate the adverse neurodevelopment consequences in preterm birth. Recommendation for DHA docosahexaenoic acid is 18 to 60 mg per kg per day and arachidonic acid is 18 to 45 mg per kg per day. Now the take home points are: thank you for listening to me. Thank you.